Well, I think we have seen this morning already many aspects about vaccines and vaccination. And of course, as any other medicines, vaccines are subject to be available to all the regulation pattern, to all the intense regulation activity. However, instead of going through the details and to the review a list of all the aspects, all the process of regulation, which could be quite boring, honestly, I think I rather will focus on some specific aspect with two hopes. One hope is to give a contribution to this tremendously important meeting. And the other hope is that out of this meeting, we will foster the first comprehensive integrated plan for communication. Because I think for the main intervention this morning, from the discussion this morning, is clear that we have to communicate, but this communication has to be specific, fine-tuned, global, and comprehensive. And this is a difficult task, because we agree on almost everything in this room, but we don't have a plan. So I took the liberty to have a very personal breakdown of how can be classified the vaccines. And I will hear from your reaction how far I am from a good approach of from how close we are to have a better approach to start to address all the challenges that we are mentioning this morning. Basically, I think there are some historical vaccines, recurrent vaccines, and emergency vaccines. Where is the differences? The historical vaccine, we can put polio, smallpox, more recently B virus, hepatitis B virus, HPV, measles. In the recurrent vaccine, basically, we have the flu. And in the emergency vaccine, we have example like pandemic and Ebola coming now. What are the basic difference here? For the so-called historical vaccine, those are those who pay the highest tribute of their own success. They are the victim. A lady here taught me in this. They are the victim of their own success, because the more they succeed, the more the memory is gone of what was before. And are those who are the most challenged vaccines. What is the approach for this? They have a very marginal regulatory activity. It's very well established. It's very automatic, I would say. There is very little to do on our side. But it's the highest challenge of a global communication. And there is an important role, a fundamental role of local authority that has to be coordinated at the level, at the higher level, by higher institution. Then we have recurrent vaccine. Those are very tricky. They have some regulatory activity. Occasionally, this regulatory activity can be very important, very crucial, because might cause delay, might cause problem, might identify problem. And these are the most difficult now, because are those who are linked to the distrust. And some data that the minister presented, this waving back and forth in the success, basically in the elderly population, pediatricians seem to be much better in conveying the message. But this waving approach is exactly these waves of trust and distrust of some communication. Last year in Italy we had some minor problem with a vaccine. Well, this was used in the worst possible way, the media have a tremendous role and responsibility. I'm sorry that all the press is outside now, but we will have a way to tell them. The media have a tremendous importance. And then we have the emergency vaccine. The emergency vaccine, we have, of course, there is a very high role of the regulatory bodies. There is a high role, and there is, for an opposite reason, the risk of another way of distrust. Because under the pressure of the motion for this emergency vaccine, the tendency of the industry, of the local authority, of the politician, is to cut corners and to try to oversimplify the way to approve those vaccines. And if we fail there, of course, we will have the major problem with the distrust. In place where Western medicine is always perceived as suspicious. You have always to prove something in addition to what they have to prove in our jurisdiction. So that's basically why I think we have to start to think and fine-tune to have a comprehensive communication with some specific attention. And of course, I will not say, oh, this, you, of course, all of you know what is the nerd effect, herd effect. I just want to have in our eyes and to convey the message how much important is that out of any yellow person, there will be any one less yellow person mean a lot of more red person. If we are able to convey this message, mostly for what I call the historical vaccine, those who pay the highest tribute to this, who get the highest benefit, pay the highest tribute if the uptake of vaccination will start to decrease. Having said that, I will not escape from my duty of saying, what are you doing? Okay, good word, but what is doing EMA there? Well, we know we have a full set, a full toolbox of provisions, procedure, process, and so far and so on. Basically, we have immunogenicity studies and efficacy studies. We have safety studies. And what is very important, we have some specific action for some specific problem. For example, the immune interference. If we have to have a vaccine, we have to prove the efficacy is toward different antigen at the same time without the immunological interference. The hexavalent vaccine is a very clear example. We have, of course, a full set, a lot consistency. And what is very important, we have the so-called bridging studies. The bridging studies are a very strong tool to streamline, to simplify, and to promote efficiency and speed in having available vaccine. And I will provide you what is the immunocorrelate. And in fact, we have sometime we need to have some protective efficacy study. But many times, as you can see, we have quite important cases, quite important examples. It's not necessary, absolutely, to redo the whole efficacy studies. That's because we can license basically vaccines under the comparative immunogenicity. And this is a clear example, the HPV, that everybody knows. The efficacy has been proved in the cohort from 15 to 25 years. But if you prove consistent immunogenicity, bridging immunogenicity, you can extrapolate and in a credible way, in a very robust way, from girls to elder women, the efficacy, you can predict the efficacy of the vaccine. So we don't need necessarily to redo all the path, to walk all the path for a full licensing in this respect. Other way to support and to promote the production of vaccine is, of course, guidelines for producers. We have guidelines for of course, flu is the most intense activity, since every year we have activity that has to be repeated, reiterated. There are now currently the revision, and there is, for those who might be interested, the public consultation will stay at EMA until January 2015. But more and more important is the discussion of how to progress and to move forward in future, how to facilitate and accelerate vaccine by investigating basically alternatives, new regulatory pathway, how to reach the efficacy, the effectiveness, the solid data about that in a more easy, fast, and safe way. One proposal are, of course, the human challenge study. The human challenge study are tremendously powerful, even very difficult to apply, not always applicable. However, it's just an example how we can identify surrogate endpoint and how we can design studies in difficult settings, difficult parts of the world, where data gathering is almost impossible. We have to find new ways to gather the data to approve vaccine without lowering the bar of both efficacy and, of course, safety. Of course, this can be complemented by the post-authorization activity. The continuous benefit-risk monitoring is tremendously important. The long-term study, of course, are some enablers to identify surrogate endpoints, continuously study the immunized population can give us important scientific information on how to move on this. Of course, the vaccine effectiveness, basically I will drive your attention on the first and the last bullet point, because to determine and to monitor the herd effect are tremendously important, because the herd effect is all about the public safety. And of course, the need for collaboration with public health authorities. These are important, even if someone can be reluctant to reduce study on something that we think is already known enough. This can give us tremendously important information. Safety, of course, there are a lot of safety studies, and I drive your attention on the last bullet point. The need to prevent the loss of public confidence. This is tremendously important. The attitude of people is to have, as our ancestor says, post the rock, prop the rock, which means after that, because of that. And this is the most dangerous thing. This is why we need this safety study to be run. Even if we think we have a lot of confidence that is something we know all about, because this data has to be continuously delivered, because the memory is short, the collective memory is short. So we have to continuously restudy and refeed with data about this, the autism, the narcolepsy, other things. Everything that happened after a vaccination is generally attributed to vaccination. and we have to study, to prove, to give the evidence, some time to accept that some effect can be generated by the vaccine. Meanwhile, for the majority, we can have a high chance to convincingly explain that are not. Coming to Ebola. It's a very hot debate. It's a very emotional debate. And under emotion, we are more keen to make mistakes. Local government in Africa are asking for something, are keen to test everything, but they say, but we want to use things that you will be using in your jurisdiction. WHO is, of course, desperate to find something useful for that. And of course, it's reasonably pressing us to say, please find a way to approve whatever drug is submitted to you. So basically now we have three major streams of thought. One is the classical, conservative, safe approach, randomized clinical trials. Traditional, golden standard, if you get there, you will be safe, on the safe side, and you will have the medicine, the vaccine you expect. On the opposite, there are, if you have reasonably preclinical studies, just escalate, produce, and give them. Which I think is a little bit too far. This is my personal view. And then we have the other way. We are exploring. We are considering immunogenicity study, some innovative clinical trial designs. We will be delivering this vaccine in a setting where, I have to say, this is one of the cases where the data gathering will be a challenge. But we can't miss. We can't miss. This is a disease where the mortality go from 70 to 30% according to what is the basic assistance you are able to give, meaning fluid and blood supply and electrolytes. How we can, on the both sides, determine the efficacy, or we miss to determine the efficacy in a set where the basic assistance is good enough, or we attribute a spectacular effect because of a reasonably good assistance. This is something that is difficult to explain to politicians and unfortunately also to WHO at this time. That's why we have to be very careful, and we had a lot of initiative. We created an ad hoc expert group. We are now in a position in 24 hours to give back where the bar is currently about the benefit risk, according to the data that the companies will submit to us, but nothing more. Then, if they want to use at the level that is not the usual level, the level that we like, it should be clear that it's not a regulatory decision, it's a political decision. It might be also a good one, but has to be crystal clear where is the bar at the time that you are starting to use massively a new drug with very limited evidence produced. So I will conclude with this. Vaccines cannot afford a failure at this stage, but vaccines per se are not a failure, are our big hope. Thank you very much.